Moving on to our next session. It has been truly said, to err is human. This applies to the practice of medicine as well. As anesthesiologists, we are subjected to a spectrum of scenarios which involve decision making and risk taking. I invite Dr. Sujit Shirsagar to join us on stage for the proceedings of our next session, Human Errors in Anesthesia.
All up on stage, Dr. Kalpana Karkar ma'am and Dr. Sari sir as the chairperson for this session. Please come up on the stage and please introduce our speaker, Rahman sir.
माझा एक फोटो असा आहे आपलं गिटार कुठे आहे मी माझ्याच विश्वास असतो मला काही समजत नसतं आजूबाजूला काय आय ऑल्सो एन्जॉय समोर लाईट मारतो त्रास आहे
Actually, I can't see Dr. Hemant Shinde's slide here, but he is one person who really needs no introduction to the people who are attending conferences regularly in Maharashtra, because he is a very popular invited guest speaker. He is a pass out, yeah, here it comes. He is a pass out of JJ hospitals, and the most important thing about him is he goes on anesthetizing the stars in Bombay, so he is a very famous anesthesiologist. He is at present Misa News editor, past secretary of ISA Mumbai, and I am very sure that he has delivered more than 250 invited lectures and keynote lectures, and I am very sure that he will have the most entertaining lecture here when he is going to talk on a sensitive topic like human errors in anesthesia.
from everywhere. Right off केले तरी मी दिसतो. Give me 2 minutes to settle this. I don't want another Amit happening. हाँ करना अपील जाना
Joy can I ask very Joy, yeah, come and Jiggy sir, come.
Secretary first.
Very good afternoon to one and all. As you can see, I am contesting for the post of National General Secretary in the coming elections. The elections are from 1st of November to 5th of November. I need not say that the last time the Secretariat was in Maharashtra was in 1985, when Dr. Das Gupta sir was the Honorary Secretary. Since then, the Secretariat has never come to Maharashtra. So it's nearly for 40 years. And we are the highest number of members in ISA Maharashtra, highest number of city branches, winning maximum national awards every year. I think the Secretariat should definitely come this year to Maharashtra. Thank you. There are many more things to be said, but I hope he's there. Jiggy, please. He is our candidate for our president. The last time the president was in Maharashtra was in 1993, again with Das Gupta sir. So he should become the next after 20 years.
Thank you. I think with your help and support we can make this happen. I would sincerely ask you to take part in the elections. And when you do vote, all of you know me as Jiggy Devetia or something like that, but this is how my name will appear on the ballot. so please don't think it's someone else. Okay. So get used to sing this year. I'm not very used to sing my whole name out except my passport. So please, I think we can do a lot for ISA if some of us are there at the center. And
All publication this name comes.
it actually comes with a V. So,
No.
anyway, so irrespective of whether you vote for me or not, I'm sure, I hope you do. Please take part in the elections, because at the end of the day, the society is what you make it out to be, and we are here for you. Every vote counts, every vote matters, and please spread the word, and please spread the message to other colleagues. Thank you. 30 seconds, no? Can I have one jam session in the middle? Yeah. See, I think 20 years back, when I had gone to Mumbai, one of the conference, that time I saw Hemant in lift. मला वाटलं कोणतरी फॉरेनर आहे मुंबईचे लोक सॉरी आहे फॉरेनचे लोक मागवले यांनी वगैरे सिरियसली आय एम नॉट जोकिंग the foreign sir.
No, but this happens to me very often. Recently, I was in some hospital. My patient asked me, "Hey, कौन है?" To the gynec RMO, she said, "Hey, तुमचे anesthetist." अच्छा, तुम्ही foreignहून मागवले? So I told her, तू सांगायचं ना तिला foreign बोलले जेवढे रुपीज तेवढे डॉलर बोलायचं. मठ्ठा आहे म्हटलं तू. समजलं नाही तुम्हाला.
So I was right.
Yeah.
That was the first human error in us.
Hey, 20 minutes आहे. हे टायमर.
ठीक आहे आम्ही मत
20 minutes. नाही ते मला टाइम करायला मला ते खूप कठीण या सो गुड आफ्टरनून एव्हरीबडी वेलकम I am in Pune. I love this city a lot. Yeah, you have always been calling me. This is my kitwi PROACT hai? 7. I have attended all as a faculty, and I want to continue this. So
Any other reason for loving us?
you want to be this reason, yeah?
कारण अजून काही स्पेशल रिझन कुठे आहे का?
So chance nahi. Yeah, बांदेला विचारा. So I come from Mumbai. This I presented recently in Dhaka, so I had given this. So I was coming from India. That's why they said these are some of the hospitals where I'm attached. See, this is extensive overview of the topic. I know a lot of senior guys are sitting here. I want you all to learn from this. Go to your department and initiate a discussion. That is the whole issue here. Nobody is blaming anybody about what is happening. We'll take a closer look with the matter and how to improve the situation. Now, to err is human. Just now somebody said this. This poet first time said this. We are not here to discuss any poetry, but in 1999, with the same name, came a paper to err is human, and it broke the silence that was kept. We were pushing everything under the carpet. United States came out with the statistics, and the statistics were horrifying. There were initial paper said about 1 lakh of people are dying every year. Then the study was repeated. It came as 2.5 lakh people are dying. And final study came a few years ago. Morning, my army colleagues mentioned 4 lakh people are dying per year in the United States of America, supposed to be the topmost country in the world. If 4 lakh people are dying because of errors which we are committing, that's huge. That's really huge. Our statistics are not there, so I don't know what happens in India. But if they are essentially killing 4 lakh people a year, I hope we are not. No, it matters exactly like that. You are by error, someone is dying means what? It has financial implications about 2 billion per year in United States of, see, this is what I was telling. Johns Hopkins, a very respectable university, came out with this, 2.5 lakhs, and final was 4 lakhs. So how we have been here, and what has been happening? So we know this figure. Everybody knows. We celebrate World Anesthesia Day on that. Boston, Massachusetts. This is what happened, first anesthesia. Who knows this? Probably 2 years down the line when anesthesia was invented, 1848, this lady died. She came for toenail removal. Can you imagine anybody dying for toenail removal? Yes, she did, because she was under chloroform anesthesia. She moved during the surgery, so the anesthetist put, the so-called anesthetist over there, he put more chloroform on his handkerchief and lagawad. She became blue and she died. So probably errors are happening from that time. So nothing has been so dramatic as that. But see, errors are, what are errors? They are unintentional deviation from safe practice, and then near misses when an error happens but it is stalled either by chance or by some measures which you have taken. And then of course there are violations. Violations is like entering your car into no entry, despite knowing that very well I know this is a no entry, but मैं घुसाने वाला हूँ. This is what happens. So that's violation. So when we do it under anesthesia, we know something wrong is we are doing, but we still do it, and that is violation. So these are certain definitions I wanted you all to get into it. And the currently data is like, suppose I am practicing, this is my 30th year in practice. I must have injected almost 500,000 different drugs. So statistically, it is impossible to avoid errors. Statistics catches with everybody. You've seen that with Virat Kohli. You've seen that with Sachin Tendulkar. So Hemant, there is no any difference. I must have committed. So all of you have also committed, are going to commit if you have not yet committed it. So it's going to catch up with you if it has already not caught up with you. So what are these? Different countries again. New Zealand study, 1 per 133 anesthetics due to incorrect doses and substitutions. Japanese study, okay? Which are the drugs? Opioids, cardiac stimulants. We always think juniors must be doing it. I'm sorry to say, seniors also are doing it. South African report found that seniors doctors are also doing it. So nobody is immune to it. 40% is misidentification of drug ampules. That happens to me also. I had to take a photograph of the drug, enlarge it and see on the mobile what is written in that ampules. I'm sure many of you are like this. Australia, 1 death per 2 to 3 lakhs. Germany, 1 lakh per 1. Taiwan is horrible, 12 deaths in 1 lakh. So that's really, so we may be somewhere in between these two probably. We are not as bad, I hope, as Taiwan, or maybe not as good as Germany maybe. So we will be somewhere in. USA is changing the trend in the sense less people are dying, but more people are landing up in the hospital and in the ICU. So hospital stays are getting prolonged. So that is what is happening. Technology is a boon or bane. That is another debate. Yes, of course it is boon, but when it is not used properly, it creates havoc. Morning, Dr. Divetia said 17% only are using ETCO2 to confirm the, and what country the study was from. Not for God's forsaken any country, but from an advanced country, if 11 to 17% are using. I know of an incident, I'm sure many of you also know, I don't want to name the hospital, but in Mumbai, the tube was in esophagus, the alarm started coming, the anesthetist switched off the ETCO2 stating, it's चुकीचं आहे. Same, जी घडून नव्हे ते घडलं, patient became hypoxic, she was in the hospital for 3 years, finally she died. So technology is not, if you don't use it properly, then it can haunt you very badly. And that's what it says, suboptimal design of equipment or not using the properly. We'll see German patient studies, their device training. This was horrified when I decided to speak on this topic only because of this particulars. In Germany, this is what is happening. People think that learning about machines is inferior. We don't want to learn about our machines. So many a times what happens is the machine is capable of working beautifully. We don't know how to extract that beautiful technology to the fullest extent, and then we don't end up using it efficiently, and then when the problem occurs, we don't know how to use it because we've never learned the machine properly. That's what is happening. Numbers are underestimated? I believe so. Why? Because gross underestimation, there are so many times you may create a complication now, patient may she may not die immediately, he or she will go home and then later have a complication, and then she'll end up having another problem later on. That doesn't reflect in any of your statistics. So it could be a possibility that the numbers are underestimated. So what are the human factors? In the genesis of critical instances, like 82% said it involved human error, breathing circuit disconnection, inadvertent gas flow, thankfully it has stopped. I remember in my St. George days, my madam is sitting here, I had switched off oxygen and nitrous was continuing because we had older machine. In 3 seconds I realized what I did. I switched it off, otherwise, and I know so many of my seniors have done it. So it's nothing new, but now of course the technology doesn't allow you to give, even if you want to give 100% nitrous to a patient. So at least that one booth is off our shoulders. Otherwise everything has gone off well, and instead of 100% oxygenating, you are giving 100% nitrous, and the whole surgery goes up waste. Syringe swap, wrong drug happening, giving wrong drugs. There are n number of instances. Mismatch, hypovolemia, equipment failure, equipment design. These are some of the human factors. Inadequate experience, overconfidence, insufficient familiarity. I already told you about the equipment. Communication is another problem. In COVID, this used to happen with those 2 masks. I don't know what I was speaking, leave alone what other was understanding. So I may tell him give atropine, he may end up giving adrenaline. Who knows? But these things do happen because your communication has to be clear. haste or lack of precaution that तो इथे केस करायची आहे तिकडे अरे आता आलो हे तो रस्त्यातच आहे what रस्त्यातच आहे तू तर इकडे आहे this even I have done. I always tell him I am ahead 2 kilometers. You know? If I am at Bandra, I tell I am at Worli. If I am Worli, I am at Hajeli. I am at Hajeli. अरे गाडी पार्क करतोय विशकेंडी मध्ये खाली. Haste, lack of precaution. So Shastri, one of my surgeon I used to work, he used to tell me one day I was very upset. He told me don't bother. Do this case properly. Don't bother about your entire list. Forget it. Nothing will happen. Do this case properly. After that I have become calm, sadhu. I don't care. By next case, गेली तर गेली जाऊ दे ही नीट कर. This is more important. Distraction is another thing. So human factors in again I'm telling you, blame game is the biggest problem. Why don't we learn? Why don't we talk about our mistakes? We are worried. If I talk about my mistakes here, probably somebody will come to know about it. I will be suspended. My job will go. At 59, who is going to give me another job? So that becomes a problem. Work atmosphere of fear and shame. अरे हेमंतच्या ओटीमध्ये असं झालं तुला माहिती आहे That is why reporting mistakes is a real career risk which nobody wants to take. So everybody behaves as if nobody makes any mistakes. Financial implications are there. Obviously, 4.2 million pounds given. Just imagine 62 claims, 50% alleged that it was wrong drug. Leave alone that there is another instance where 20 cases where it was known patient is allergic to this particular drug, still the same drug was given. Now what do you say to that? That's that one. 20 claims where the drug was given into a patient where it was known. Awake paralysis is the biggest problem. Spinal opiates, IV, patient landing into ICU. All these are adverse outcomes that usually happen. And why do they occur? Misjudgment, overconfidence, failure to check equipment problems, again inattention, haste, inexperience, communication problems. So it all comes down to again and again is into something which we are not doing. Sorry, I went ahead. Who is solely, not always the anesthetist is responsible, sometimes it is an organizational issue. Like what? I want a CMAC. Okay, CMAC costs 6 lakh minimum if it's single blade. My management will give me 1 lakh का कोई तो video laryngoscope. At the time of when I need it, it doesn't work. Who's responsible? The tube didn't go, hypoxia, patient died. Who's actually responsible? It's the organization who gave me a third-class instrument. So who's to be blamed? That's the problem. Suboptimal organization of the workplace is the biggest problem. Technical devices of suboptimal design. Tendency from hospitals to it is very easy to blame Hemant Shinde rather than accept the entire blame by the manager and the management. So that's the problem. Remember, a bad system will always beat a good person every single time. Tighter budgets are happening. 24 hours OTs are happening. The other day I did a shoulder arthroscopy from 10 p.m. to 2 a.m. 138 kilo patient. 10 p.m. to 2 a.m. Is it a time to operate? That's crazy. But the list was busy. Nobody was going to get any OT. So we had to operate. Surgeon was traveling abroad. Squeezing more and more surgeries in the same hour. Assembly line. Hinduja Hospital doing 80 cases per day. Understaffed. Overworked doctors. Inadequately trained staff. No help in the middle of the night. I'm doing 138 kilo patient. Luckily nothing happened, but that's luckily word is not happening. Yeah? Complex workplace we work in. You want to see how we work? Overview. This is a typical OT. Come on. The data that is bombarded onto you is so much, and how are you going to assimilate that data and take a reaction, and that reaction has to be correct in split second of time, or else you lose your patient. That's the work which we do, and this is how it is. So we are into like this. 48% of the anesthetists use the equipment without reading the manual. 60% do not follow the manufacturer's check at all. I've seen so many of my friends bypassing the machine check. Please don't do it. Please don't do it. Allow it to run. Let it take those 5 minutes. 40% of anesthetists perform no checks at all. How can you work like that? And then of course, we are doing our own thing, surgeons are doing their own thing. Suppose the patient collapses, together we should be addressing the problem. Instead they are doing their thing, you are doing your own thing. What will happen? Distractions is the biggest thing. 32 operations, just see the statistics, 3,500 potential instances in 32 operations, so like almost 100 distracting events per operation going on. Most of the time it was the other anesthetist from the other OT walking into your OT and asking you, PROACT कैसा था? किस पे बोला तू? Exactly इस पे ही बोला मैं, इसलिए बाहर जाके खड़ा रहे। मैं कॉफी पीने को आता हूँ तभी डिस्कस करेंगे। That's the problem. Look at the amount of distractions that are happening. One distraction every 4 minutes. In induction it is 3 minutes, maintenance it is 6 minutes, emergency it is 2 minutes. It is altering the physiological parameters of the patient. हे इथलं कशाला गेलं? मला दिसत नाही रे, टाइमर गेला माझा.
Distraction होतं.
And then it leads to delays in procedure. आता माझा टाइम वाढणार आहे. So prevention of smooth induction of anesthesia happens. You don't know these things are happening, and then it's completely avoidable. So there is no need. The guy can come and talk to you later. Look, this alarms, that is the another hit. Have you ever walked into an ICU when alarms are going on and people are oblivious to the fact that there are alarms happening, and I am like looking here and there because I go once in a while only to transfer a patient, and then down sister udhar de sir kuch nahi because बरोबर है 350 alerts per bed, 771 alarms per day, 90% them are completely useless. Then obviously she is going to ignore it completely. Sir कुछ नहीं होता है. अरे क्या कुछ नहीं होता है, देख तो कोणतरी आता ते लाईन वर बोललं ते तसं काहीतरी झाल्याशिवाय यांची जागे नाही. Rashmi spoke about it. Yeah. So sleep deprivation is another biggest thing. This is a classic study. 18 doctors, they were kept sleep deprived, and see what happened. Poor attention, longer response latency, more errors. No, more than that, something very interesting happened. They started behaving as if they have had alcohol. असे बरेच जण तसे वागत असतात, but this was not like that. They behaved, their reaction time was worse than that 0.05 level of alcohol. And that's where their thinking was cloudy. They couldn't take correct decisions, and that is the problem. So and this happens only after 18 hours of lack of sleep. I worked so many times I have not slept after for 18 hours or sometimes even more. So response speeds go down and everything gets halted. So sleep is very, very important. And then this is another thing. There are always two victims. Your patient goes away, but the doctor also carries the guilt all your life. I know of an instance where orthopedic surgeon and the anesthetist were best of friends. Anesthetist gave anesthesia to the orthopedic surgeon. This happened in Gujarat. The orthopedic surgeon had a cardiac arrest. He died, and the anesthetist committed suicide in the parking lot. That's the second victim I'm talking about. So there's fear, there's guilt, there is anxiety that somebody died in my hands, and that carries the weight all your life. So lack of personal and administrative support. I know so many instances. There is no time, otherwise I would have told you a few more. But this is what happens in our life. We don't get supported by the admins. Our families are the only support you have, and if you don't have even that, you are in for big trouble. Approaches, how do we improve? Obviously, I've got 2 minutes. I'll go another 2-3 minutes extra, and then I'll conclude. So blame game culture we have to come out with. Let's be open about it. Even in a closed door format, discuss your mistakes which you have done. That I'll learn from your mistakes, you will learn from my mistakes. Collectively, we'll grow up. Learning from them is most important rather than... So to err is human, to cover up is unforgivable, and to fail to learn is inexcusable. Yeah? That is what is. And here is the aviation industry is far ahead of us. You dying is 1 in 30 million under flying, and you dying is 1 in 2.5 lakhs. So we've come a good long way, but we still need to cover a lot of way. Why? Because they have, Boeing and Airbus will make 2 planes, but the display will be standard. Here Draeger and GE make different machines, everything is different. Something is on the left, something on the right. You don't know. So multiple backup systems they have constant inquiries, they have fixed hours of working, and still Times of India the other day there was a thing that 67% of the pilots do feel that they sleep on the flight. Can you imagine anesthetic sleeping? Though I know of you. I'll cover, don't worry, I'm coming on, it's almost now getting over. So aviation industry, what have they done right is this is what they have done right. There is a pilot immunity. They have fixed protocol. As against medicine, we have this, we demand perfection. Nothing should go wrong in your OT, otherwise you are the whole and sole responsible for that. So we have an intolerance to morbidity and mortality, attributes error to carelessness. याच्या ओटीत काहीतरी झालं म्हणजे हा useless आहे. This is not done, this is not right. And that is why this constant fear is always there in my mind. So how do we improve this situation? This is the last part. I know I'm going to overshoot by 2-3 minutes. First of all, learn to admit that mistakes are happening, and mistakes is better than faking perfection. So nobody is perfect ever in this room. It neither was. Report your errors, not for gossip, but learn from them. Analyze the data, what went wrong, how it went wrong, root cause analysis, and then come to conclusion and safety recommendations. So checklist will matter. We have to have the checklist, and that really helps. Then of course, teamwork, decision making. About teamwork, I would love to see you, show this video. It's amazing. Just look at it, how do they change the tires. It's hardly few seconds. Hey, आवाज वाढव रे. Now you will see this in slow motion. That's how teamwork should be done. So like if you have a laparotomy, epidural is to be put, block is to be given, central line, arterial line, divide the work, everybody reports to you once the job is done, and that's how it happens. So that is a teamwork. We have to inculcate those habits into it. Simulation, someone spoke in the morning, that is an excellent way of learning, so that keep doing same thing. You can imagine the Ferrari team must have worked so many hours to have this perfection. 3 seconds, 1, 2, 3, 4 tires gone and Schumacher has left. I mean, what kind of work they must be doing it. So finally, to conclude, we have to understand that blame culture in medicine is alive, but change is coming slowly. Now hospital must back doctors if they want us to report, Unless they support me, I am not going to report, I am going to cover the thing under the carpet. Error should be used as a tool from which to learn and not to crucify me. At the same time, we must know our jobs, like learn about your equipment, sleep adequately. Again and again I am saying, sleep adequately, rest properly. Next day if I have an important case, like someone say I do a lot of stars, I sleep a lot before anesthetizing Katrina or anybody because I am worried. Next day if she doesn't wake up, that will be my last day when I will sleep. Make equipment as user-friendly as possible. And finally, then only future stakeholders will come to realize that a blame-free culture of reporting mistakes is going to benefit all of us, hospitals, staff, as well as the patients. Thank you very much. Any questions? I'll be more than happy to answer.
I request the chairpersons to kindly felicitate Dr. Himanshu.
I think the organizers have given us a clear this thing that there should not be any discussion, any question answer. But I just want to add something that look alike, spell alike drugs is a very, very important source of
Absolutely. I know an instance where, I'm very sure you also know this. My friend, plastic surgeon from Thane, he used to stay on the 4th floor. His hospital was on the first floor. 2 boys were operated for circumcision. The staff from Chilla and नीचे से, sir, हे दोघे vomiting करतायत, काय देऊ? त्याने वरून सांगितलं पेरिनॉम दे. ही फ्रीज मध्ये गेली, तिने पॅव्हिलॉन दिलं. Both the brothers died in front of the father.
This has happened even in certain hospitals. This has happened in Bombay, I think in Kama Hospital.
This is sound alike, sir. This is
That is sound alike.
This is sound alike.
And look-alike drugs that
Tranexamic acid
happened
and
in my hospital.
tracurium gone into the this.
In my hospital, I'll tell you something interesting. See, atropine and adrenaline were looking very similar. One case during reversal developed ventricular arrhythmias. So we reverted it. Again the second case, then I got worried. I thought something is wrong. That case also got reverted back. The patient had to be defibrillated. The third case, before it happened, I checked it and it was adrenaline instead of atropine, which was being mixed with glycopyrrolate. Instead of glycopyrrolate, they were mixing
So
atropine.
look alike, sound alike, they have a red label these days, they have to be kept aside. So all these NABH accreditation has really done some good things to us. We've realized that these things are happening.
In accreditation, it is specifically mentioned, and anesthesia department is taken very seriously.
And your fridge cannot be
Accreditation
same
process.
as their fridge.
And the checklist,
Your fridge has to be
checklist and
separate.
safety checklist is mandatory. And this since 2017, the theme is going on to globally medication without harm. What madam was trying to say, which
Pre-filled
includes
syringes,
everything.
pre-filled syringes is another thing,
Yeah.
sir. But sir, त्याच्यात सुद्धा मी atropine न वाचता adrenaline दिलं तर pre-filled also is not going to save me.
See, very well-known companies we have that red reduction band.
High alert.
I asked them why this is so. नाही म्हणे आमचं branding असं असणार.
Branding, that is
Our
because of
branding,
high alert. Red is for the high alert medicine. Red is for high alert medicine.
Yeah.
I request the chairpersons to
In
felicitate Dr.
Bombay,
Hemant.
I think in Kama Hospital, 20 children were given scoline instead of some vaccine.
Vaccine. Jiggy was saying this. Thank you. Thank you. मी म्हणणार तिकडे.
I request Dr. Bhatia sir to kindly come up and felicitate Dr. Kerka and Dr. Sai. I request chairpersons to felicitate Dr. Sujit Shirsagar.
After Hemant's post-lunch session, I'm sure everybody is awake right now. So I hope I can live up to what Hemant has done over here. I mean, he's a complete showman. We're going to discuss about the pros for anesthesia for laparoscopic ambulatory surgery. So since we all follow most of what the NHS does, it was in 2004 that they came up with 10 high impact changes. The document was released, and the principle was of treating all patients in daycare surgery as the default option for elective surgery. And this is something that we try to do now as much as possible in India. And if you look at most of the OT lists that are there in most of our hospitals, probably about 40 to 50% of them are daycare procedures compared to what it used to be probably about 10 or 15 years ago. Choosing wisely, this is another document that came out in 2016 where the new NHS, they had the top recommendations that all day surgery should be considered default as most surgical procedures should be considered as daycare surgeries. And for the patients, they were actually educating the patients over there that if you have a surgical procedure which is done as a daycare, and it should be considered as a daycare, and if you're suitable in all those procedures, and because of that, they will be able to accommodate about 186,000 more patients can be treated within that same budget. So they were trying to talk to the patients as well as the surgeons over there. Now the most important thing for daycare surgery is the entire surgical pathway that we all know about. We need to identify the appropriate procedures first of all which are there, and a lot of our laparoscopic procedures, since it's becoming more and more minimally invasive now, are going to fall into this category. Identifying operation theatre lists where you can accommodate these procedures as fast as possible, ensuring that clear pathways are in place in your nursing staff, in your protocols, so that you can early discharge these patients is very important, and providing clear per operative patient information, ideally in writing, is something that is very, very essential. The most important things that we need to consider are the patient selection, the anesthetic methods that you're going to be using, and the post-operative management of these patients. The patient selection is most ideal because most of the patients are eligible for ambulatory surgery, whether it is you're going to do it minimally invasive or you're going to be doing it open. And patient choice has also become an important factor. A lot of patients don't want to stay in the hospital for long periods of time. So patients are asking that they return home as early as possible. Now the surgical considerations are going to be that they do not carry a major risk either of a major complication like hemorrhage or cardiovascular instability. Of course, lots of minimally invasive surgical techniques are available now, and laparoscopic procedures are done on an OPD or a daycare basis very, very often, and this has been there right from about 20 years ago. When we were residents, we were doing in absolutely OPD patients, we were insufflating air and doing tubal ligations on a OPD basis, where patients were discharged in about a couple of hours. Patients want to resume normal functions as early as possible, and that's where your ERAS protocols are all coming in, where early oral drinking and early return to normal functions as soon as possible, early mobilization, at least to a large extent before discharge, so that these patients can reach home and manage themselves at home. Long-term professional care or observation after surgery is usually not required if they're well educated about their procedure in the post-operative, what's going to happen in the post-operative period, and the surgeon should have sufficient experience with the procedure and a low complication rate. That is very, very important. Of course, social considerations, that there should be somebody to look after them at home. There should be somebody to accompany them once they are there. They are not allowed to drive for 24 hours after anesthesia and sedation, and the home environment should be suitable for a post-operative care. The medical considerations that we all know now, that the BMI is not the only indicator for denying somebody a daycare procedure. High BMIs are not an absolute contraindication. It would depend upon the size kind of surgery that the patient is coming for. And of course, chronic but stable illnesses prefer to be at home because it interferes less with their daily lives. So patients who have had medical conditions like diabetes for a chronic basis prefer to go back home so that they can continue with their daily lives. Unstable medical conditions like unstable anginas, poorly controlled diabetes are not appropriate for ambulatory surgery at all. Of course, there's no single anesthetic or a method which is appropriate for all. There are controversies whether you're going to use TIVA, whether you're going to use inhalational, whether you're going to use general, whether you're going to use regional anesthesia. And of course, the most important point is the post-operative pain management and the post-operative nausea and vomiting. If you can get control on those two, then you can do lots of procedures, including lot of laparoscopic procedures, which are going to be simple procedures done minimally invasively. Now the advantages of the laparoscopic surgery, as we all know, are reduced post-operative pain, improved post-operative mobilization, return to activity much quicker, smaller scars, lesser pain, lesser handling of organs, and reduced wound infections, and all this reduces the hospital stay, and then you can discharge these patients much, much more earlier. So coming to that, of course, whatever happens with the pneumoperitoneum, all of us know the physiology. That will be discussed probably in the next PROCON session also, where they're going to debate whether it's going to be regional or whether it's going to be a general anesthetic. I want, Jui, you got.
The Jui Geet now will be talking on the concept.
Still wants to have jam session without slide. There is a good prize at the end. I am going to do that. See, I got another lecture after this. Then I think Archana, we are like night watchman. Wickets then somebody has to go and chip in basically. So that is what we will be doing. Anybody? Just tell me. Otherwise, I can keep on going.
Jam after jam.
Jam after jam. Till you get jam. Till you get jam. And Hemant Shinde somebody has to be on the pitch. Otherwise, and roaming around. Otherwise, it looks very blank and bland, vacant. Yeah. I think
Which star is your patient?
No?
Which star is your patient?
That is very much confidential. So Hemant Shinde, ये तो म्हणतोय Katrina वगैरे. I don't think Katrina वगैरे. I know Hemant very well. आता नवीन कोण आहे Katrina आहे का चला Katrina का नाम दो. ये मैं Katrina का नाम 10 साल से सुन रहा हूँ. Thank you.
Good afternoon. I don't agree with the statement that laparoscopies can be performed as daycare surgeries. So now we have all this data, like with laparoscopies done majorly, like around 80% of the cases are done in US and 75% in UK as daycare surgeries. But does this fit in for our Indian scenario? That is the main question. So now when we are talking about surgical factors, nowadays it is not limited to just simple surgeries like lap chole, lap appendix or hernia repair. More complex surgeries have been performed with laparoscopy. So like many laparoscopic gynecological surgeries and also oncosurgeries. So as the complexity and spectrum of surgeries performed via laparoscopies is increasing, also the associated complications go higher up. Another thing is pneumoperitoneum, which Dr. Taslim has already been touched upon. But there are so many physiological changes that occur with pneumoperitoneum, and they have so many respiratory as well as hemodynamic changes. Next is anesthesia related. So the first and foremost is pre-anesthetic evaluation. In many of the institutes, like I come from a teaching institute, so many times PSC will be done by PG, something may be missed. If for daycare surgery, patient is arriving on morning of surgery, if something is missed, that review is not done. Another thing is with so many complex surgeries being performed, ASA grade of patients also is going higher up. We know that India is diabetic capital and also it is hypertensive and maybe IHD capital also. So with all this, risk is just going up, right? So is it safe enough to send back the patients? So you have to choose between comfort of patients or safety of patients. Next thing is also type of anesthesia that we choose. So whether GA is chosen, there are so many other complications that can occur. So problems like sedation or respiratory depression or PONV, which is associated because of pneumoperitoneum and also because of various drugs that we use. So these are major deterrents for early discharge.
even with the use of regional anesthesia, like laparoscopies can be performed under spinal anesthesia or epidural. But then the recovery time is highly variable and it ranges out almost from 6 to 18 hours. So that is also against early discharges. And of course, post-op complications like pain. So though minimally invasive surgeries are associated with minimal pain, sometimes it is intractable. Diaphragmatic irritation, shoulder pain, these sometimes cannot be taken care of. Also, there's a limitation to a variety of medications that you will be using because we want to send the patient back. So then how to take care of that? And our patients, see whether they are uneducated patients or highly educated, both the spectrums are dangerous. Some are Google doctors, so they will have their own thoughts and they already know the treatment, right? So how to get the information correctly, how to expect that compliance to all the instructions will be correct. So that also is a problem. And in Indian scenario, we always feel, right, एवढी मोठी सर्जरी झाली आहे, थोडं तर सहन केलंच पाहिजे. So this may be a problem, like some complications may not be detected or may be overlooked and the patient may not be seeking help at the earliest. And thus there is delayed treatment and this may just land up into further complications. So what I feel, it's always better to make sure, even if the patient stays in hospital for some extra care, the cost in totality should be looked at. One more thing is healthcare infrastructure. We all know that, despite so many new and big hospitals coming up, there always is a shortage of beds. So we really have to, hunt and book the bed. And then, like with daycare, if the patient goes back, how to go about emergency admissions. How are we going to create an emergency bed available for a patient who has landed up into complication? So that is one major problem. Another thing is like the guidelines that are followed in UK. So there they are very fixed, like a patient goes to a hospital which is nearby. But in us, we go to the best hospital or non-paying patients go either to Sassoon or maybe they will come to me to Symbiosis because there's free treatment. So then how to reach when an emergency occurs? We also have lack of community nursing or a defined referral pattern is not there. So this was one article in IJ which shows that despite having so much of load, we hardly have any beds available. Also, we don't have dedicated daycare centers. So we also always squeeze in our daycare patients in between the routine operation list. So as an anesthetist, I will always prefer to start a major case and a complicated case in the morning. And I will always feel that some minor case which is taken as daycare laparoscopy should be done towards the end of the list. So then do we have time which is enough for post-op monitoring and to check whether the patient is ready for discharge? This I don't have to say. Daily we struggle to reach the hospital and then this is a universal picture in India, I think. And again, now laparoscopies are offered to all the patients, whether they are non-affording or affording, because it has been there. So this, whether by sending them home, we are not taking care of real healing and proper recovery. So to summarize, I don't agree with a blanket statement that laparoscopies can be taken under daycare surgery. Thank you.
You still want to defend?
Yes, of course, I definitely want to. So, what is the actual definition of daycare is basically admitting the patient on the same day, operating on the same day, and discharging on the same calendar day. Unfortunately, that does not happen in most of our situations. That's because of probably the Mediclaim which is coming into play, and because the operation theatre list cannot accommodate them for those many hours if you have to operate them probably in the early half of the morning or the middle half. So most of the surgeries that are being done are called daycare, but they are probably a less than 24-hour admission in most of what we are doing. So what should the consensus be? It should be that daycare surgery, as a default for all elective surgeries, you should ask why not rather than why. Is something that we need to educate most of our surgeons. And like you said, there's always a crunch of beds. So why not send them home early and get more beds? So I think it makes more sense, and that's what the NHS has done since 2014, and they've been quite successful. They've been able to accommodate so many cases, so I'm sure we'll also be able to do that. An effective pre-operative preparation, like you said, is very, very essential, and that's where the communication between you and the surgeons and the surgical team comes into play, where of course you see them. You see them the day prior, you see them a week prior, you prepare them for surgery, and then you take them up. Whether it's laparoscopic or any other daycare surgery, we're all diverting from only laparoscopic surgeries, but it is all about the daycare surgeries. And of course, the anesthetic technique, there's no specific technique that is required. As long as you maximize recovery, minimize the post-operative pain, and minimize the post-operative nausea, vomiting, we'll be able to promote more and more patients into daycare rather than in-house and inpatient surgeries. You came with this article, or the same one, okay? So I'd like to point out something from that article also. Majority practicing anesthesiologists concur that patients undergoing daycare surgery has obvious health and cost-related benefits. Only thing is there's a lack of widespread acceptance of daycare surgeries which is being observed in India. Unfortunately, this consensus statement was based only on about a small sample size of 162 anesthesiologists. Maybe if we do another consensus report, maybe the outcomes will be more different and the outcomes will be more different. The sample survey size was very, very small. And of course, there's a need for training of anesthesiologists and training the surgeons whom you work with, training the entire team to convert more procedures into daycare procedures. Lack of insurance coverage, like I mentioned earlier, by insurance companies is one of the reasons why you want to keep the patient till the next day and discharge on another date so that the insurance is covered even for small little procedures. So that needs to be changed. And of course, infrastructural issues that have been mentioned, and the mindset of patients in India where there is a fear to get discharged early that has been mentioned. The most important dictum that we all need to take back home today is a proper prior planning prevents any poor performance. That is something that is very, very important. So plan prior, ensure that you have seen these patients and decide whether it can be done as a daycare or not as a daycare. Pre-operative planning will of course keep you vigilant against all those pneumoperitoneum issues that we all are worried about. And we are moving now from the era of laparoscopic surgery to robotic surgeries. Robotic surgery is going to become more and more cost effective over a period of time. So most of your hernias, with the advent of the CMR robot, with the advent of the SSI mantra, is going to reduce the costs of surgeries. So are we going to stop doing these as daycare procedures just because we're doing a robotic procedures? In fact, the robotic procedures are going to improve the conditions of pneumoperitoneum. You don't need to work on high abdominal pressures. You don't require pressures which are going up to 15 millimeters of mercury, which is causing most of your problems. You can work at pressures of 5 and 6 when you're doing robotic surgeries. So we are soon going to be moving over to that. Thank you so much.
Please.
I think smart selection of patients and developing protocols for the institute are really required, and then we can go ahead with what.
Yeah, we now move ahead to the next session, laparoscopy under regional anesthesia. For that we have Dr. Ashish Pathak and Dr. Pallavi Bhutiani to speak for and against the regional anesthesia. Later towards the end.
A very good afternoon. It's very difficult to catch your attention at this point of time, honestly. One simple question before I start my debate. How many of you, I'm asking a very ulta question. How many of you give general anesthesia for laparoscopic cholecystectomy? So exactly, I'm debating against all of you. Yes, because I also give GA. That's unfortunate.
We have done 100, don't worry.
Thank you. So, laparoscopic under regional anesthesia. I'm speaking on the pros, not being heartily convinced, honestly speaking. But you know, traditionally we are always doing laparoscopic surgery under general anesthesia. Regional anesthesia is emerging as an alternative option. Why are we so concerned about giving GA? And why we are so concerned that we have to give GA to the patient? Why not spinal? The issues which are usually cited are the high sensory level that is needed, and because the sensory level that is needed for laparoscopic surgery is extremely high, we have severe hypotension that has to be tackled. The second is shoulder discomfort, which is one of the major reasons why we have to give GA to a person who is under regional anesthesia. And the third is the pneumoperitoneum that is causing respiratory discomfort. Now you look at the advantages. We always look at the side effects of the problems that we are going to face. We are never looking at the advantages. These are the advantages we always say about regional anesthesia. Better laparoscopic condition due to profound muscle relaxation, an awake, spontaneously breathing patient, prevention of airway manipulation, obviously less incidence of PRV, a lot of advantages, shorter recovery time, effective post-op analgesia, and in a condition, now we are staying in a cocoon of a corporate hospital. Majority of people work in a corporate hospital, we completely forget there is a huge number of anesthetists who are practicing outside where they have to give care at a reasonable cost. I am highlighting the concerns. We say it is hypotension that is a concern with spinal anesthesia, and that's the reason we are supposed to be giving general anesthesia to the patient. What does the literature say? The incidence of hypotension is, yes, as high as 20%, but that can be easily tackled with giving fluids to the patient by giving vasopressors. We do it left, right and center for a cesarean section. Why can't we do it for the laparoscopic surgery? First concern highlighted. Second is shoulder tip pain. The incidence of referred shoulder tip pain is 0 to 37%. One of the major reasons why a person under spinal anesthesia is put off to sleep. But if you are taking proper precautions, now you know the etiology is thought to be subdiaphragmatic irritation of the peritoneum. But this is basically a surgeon dependent sorting out of the issue. If the lower means abdominal pressure is kept to less than 8 to 10 millimeters of mercury, and the surgeon is instilling local anesthetic, and as an anesthetist, if you are giving the block up to T4, the GA conversion because of diaphragmatic irritation comes down to 0 to 2.5%, which is acceptable, very much acceptable. The second concern, and the third concern now, the respiratory issues. These are again going through a lot of issues, means obviously it is a proven technique for laparoscopic gynecological surgeries, but not very comfortable for a laparoscopic cholecystectomy. Obviously, data from healthier women undergoing laparoscopic surgery, they say that because awake woman is able to increase the respiratory rate and minute ventilation. Even if you look at the Miller, it says that the amount of minute ventilation that you have to increase to wash out the CO2 is 30 to 40%. We walk and we increase our minute ventilation by 30 to 40%. So that is what it is. Insufflation pressure and time are the main factors affecting CO2 absorption. That's a third concern. Now I will just highlight a few evidence. Now obviously these are the three concerns why we give GA. These are the three concerns, how they have to be managed, and why regional anesthesia, because of 7 or 8 benefits, should be one of the priorities. This is one evidence, laparoscopic cholecystectomy under spinal anesthesia versus general anesthesia. It's a meta-analysis. What does the conclusion say? SA as anesthesia as a sole anesthesia technique is feasible, safe for laparoscopic cholecystectomy. This is an article published in the Chinese journal. Laparoscopic surgery using spinal anesthesia, conclusion says laparoscopic surgery done with the patient and the spinal anesthesia has several advantages compared to general anesthesia. Spinal versus general anesthesia for It's a old paper, interim analysis of a controlled, randomized controlled trial. Look at so, it says spinal anesthesia is adequate and safe for laparoscopic cholecystectomies. World Journal of Surgery and Surgical Research highlights a lot of advantage, and this is an Italian paper, says it is fairly safe, fairly good. Anesthesia for laparoscopic surgery, journal versus regional anesthesia, a paper that is presented in the Journal of Regional Access Surgery does say regional should be one of the preferred options. And I can go on and on because the timing of the debate is like 6 to 7 minutes. Again, this is a paper, spinal anesthesia, this is an Italian study. Again says spinal has got absolutely no disadvantage compared to general anesthesia. Where do we stand? In a country which is cost conscious, which not of lot of benefit, means obviously we do say, as I said, it's very difficult to debate an entire audience, including me. I'm still trying to prove a point that regional is a fairly safe technique, provided you're working in a setup where you can practice that, provided you're working in an environment where you can practice that, and provided you yourself are convinced it is a technique that can be followed.
Provided surgeons are competent.
Yes, and we have a competent anesthetist. Obviously, there are a lot of plus and minus. Now, I am not going to debate with my very good friend Pallavi, but before Pallavi comes, I just want to highlight a couple of slides on a small course. It is not a conference, it is not a CM, it is a small course I am going to conduct in Manipal Hospital. Just a couple of slides. This is what I have planned for the DNB theory examination, purely because I have seen a lot of failure in the DNB theory examination in the recent past. Just a couple of days course, because this is comes from me being trained in Liverpool Mercy Deanery, and where we used to do a lot of training on the short answer questions. So this is my aim, and I am requesting all your final year students only, the people who are sitting the examinations. I am going even 1 year back, but people who are sitting the examination not to miss this course, because what I am going to train them is how to answer the difficult question, how to manage time, how to allocate your time to questions, and how to write a model answer. Small slide away from the pros. This is the pro that I am looking for. Thank you.
Thank you. Now I call upon Dr. Pallavi Bhutiani for the cons.
Very good evening and my namaste to all. Excellent presentation by my co-debater and my friend. And now I am here to defute the claim that regional anesthesia is favorable for the laparoscopic surgery. I'll open my debate with asking you a few quick questions. How many of us give regional anesthesia for laparoscopy surgeries? How many of us use regional anesthesia as a sole anesthetic in a laparoscopy surgery? And how many of us give regional anesthesia in high-risk cases in laparoscopy surgery? Confused? Let's go ahead. Actually. Here my aim is to assess the feasibility and outcome of laparoscopy surgery under regional when compared with the general anesthesia from the point of view of surgeons, anesthesiologists and patients. So, as we all know, pneumoperitoneum is an integral part of laparoscopic surgery, and this pneumoperitoneum increasing intra-abdominal pressure leading to various pathophysiological consequences causing cardiorespiratory disturbances. And this is what we anesthesiologists should clearly understand and be prepared to prevent, act accordingly and address if we come across such complication. So what should be our goal? It is a stable cardiorespiratory function and allowing the minimal effect of these pathophysiological changes during the surgery on the body's vital system. This is very important for laparoscopic surgery and rapid recovery from the anesthesia with minimal residual effect. Mind well, here the laparoscopy surgery is the minimal invasive surgery and it is not the anesthesia. So please do not mistake it. So we need to have a broad perspective while dealing with such kind of patients.
So traditionally, GA is considered as a more acceptable and safe technique of anesthesia in laparoscopy surgery, as it precisely controls the ventilation, maintain hemodynamic stability, and what it offers more is it keeps your patient calm, comfortable, immobile with good muscle relaxation. Good for anesthesiologist, good for surgeon. But it is of course not without any complication. But with newer drugs coming and monitoring in anesthesia coming, we can use all these anesthetic, analgesic newer drugs with rapid onset of action, short duration of action. We can titrate these drugs easily so that we can get a smooth and rapid recovery, so that making general anesthesia as a favorable choice even in daycare, laparoscopy surgery or fast track surgeries. Newer antiemetics, dexmedetomidine can help in suppressing the stress response. Even use of LMA we can avoid endotracheal intubation and so the complications. So this really broadened the armamentarium of general anesthesia. It is made more safer with less complication. Recently, recently we have come up with the regional anesthesia as an alternative to general anesthesia for laparoscopic surgery. But still it is not a choice of anesthesia by many, because it is having many problems. So let us see what are the issues. Regional anesthesia demands a high level of block. So wide sympathetic blockade with pneumoperitoneum, with level with position, Trendelenburg position, all these leads to risk of aspiration, hypotension, respiratory insufficiency, patient complaining of shoulder pain, as already discussed by Dr. Ashish. So all this leads to continuously complaining patient, uncomfortable patient. This makes the surgeon also uncomfortable. Sometimes he has to also stop in between, and this would also increase the surgical time, and even it is difficult to perform the complex surgery. So when you look at the complication rate is really high, almost 20, 40%, 50%. So we can't ignore with it, even though if we can deal with it with pharmacological agent. But here anesthesiologist has to rush to control the hypotension, make the patient calm, giving IV anesthetic. This is again adds to the respiratory depression of the patient. So there are many studies comparing regional versus general anesthesia in laparoscopic surgeries, and when you summarize, it says it is one of the alternative to general anesthesia in particular cases. But when you look at the limitation, here the major focus is on the postoperative pain or nausea, vomiting, and most of the literature is on the laparoscopic cholecystectomy or diagnostic gynecological procedures or small duration surgery. It has a small study design in healthy patients, already limited intra-abdominal pressure, so already there are many limitations. While searching the literature, I came across a very beautiful editorial published in recent journal of Saudi Journal of Anesthesia. This is why you should not use spinal anesthesia in laparoscopic surgery. So it says a careful evaluation of risk-benefit ratio does not encourage the use of regional anesthesia in laparoscopic surgery, and there is no significant short-term or long-term advantage with it. Let us see the surgeon's perspective. Most of our surgeons are trained in in general anesthesia, so they are not very comfortable in operating on regional anesthesia. So also they say limiting the pneumoperitoneum, we can make the patient more comfortable, but this will add the technical difficulty for the surgeons, difficult to perform complex surgery. Also learning curve of surgeon is also very important. Surgeons are not very satisfied working in regional anesthesia. Of course, anesthesiologists, achieving high level of block is not possible for everyone. It needs proper knowledge, skill, to get high level of block, manage complication, sometimes needs to conversion to GA, manage the inadequate block. So it really needs expertise, skill and competency. What about the high risk cases? Operating on patient with cardiopulmonary low reserve, it exacerbates the pathophysiological consequences of pneumoperitoneum, and it may not be tolerated by all these patients. So there is no option but to GA. So here my conclusion is the regional anesthesia should be considered less reliable and safer than general anesthesia for the laparoscopic surgery in conscious patient.
Poonam asked me, do you want to contest? I said, I want to concede defeat. Obviously, I could not convince myself, but because it was a point of debate, I tried to find a lot of studies. I could put in a lot of efforts to get those studies on board, but unfortunately, I don't want to contest a wrong debate.
Okay, combine it.
Is there anybody in the audience who still regularly does it under regional?
Previously,
Currently.
main reason is, as Pallavi said, surgeons are not serious for that. New generation doesn't understand the importance, neither they will be comfortable under only regional.
But probably this is because
But
we are
your
taking this in
anesthesiologists
Pune.
are also not that.
If you go to Satara or somewhere,
taking high level of
There are many people carrying notes.
But they are giving lot of recommendation.
yeah, finally patient is successful.
So only selective cases can be done. Selective cases, only pelvic surgery cases, with all these things. And when the surgeon and anesthetist.
Selective surgeons.
Patient with selected
Surgeons.
That is the bottom line. Yeah.
So we move ahead to another interesting pros and cons session. We have supraglottic airway devices in laparoscopy,
Yes.
and for that we have Dr. Yogen Patsa and Dr. Abed Parkar.
The only people who have asked me to give regional anesthesia for laparoscopic surgeons are the ones who are trying to cut the budget. If that is the primary aim, I think, have we ever asked them not to use Vicryl? Have we ever asked them not to use this insufflator and a striker TV and this and that? We have not. Then why we should try his 200 and 300 rupees on propofol? I think at least I am totally against it. Sorry. What is right for a person who is practicing in suburban area of Mumbai or far suburbs of Mumbai or deeper in Maharashtra will not be right for somebody who is practicing UK, US. They are not going to accept. So I think we'll have to be a little careful on that issue. Sorry for I jumped over to the last topic. Thank you. Where are you? Anything that is going to be different and unconventional. So anything that is different from routine is going to have lots of cons. There is no question about it. But all said and done, that cons is here to stay. Let us remember one simple thing. Everybody, all my surgeons were against. अरे कसाला लॅप्रोस्कोपिक cholecystomy मला 25 मिनिट लागते कसाला करायच्या but they have vanished. All my gynec used to say, my surgeon, he removes vaginal mastectomy in 25 minutes. Period. 25 minutes. तो सांगतो आता कसाला ते 1.5 तास ते टॉरी लावायला लावतात हे लोक. Why? But he has vanished. He has vanished. And I used to tell him, sir, when the market needs pizza, you should not try to push dhokla. You sell what the market. I'm sorry, I'm a little slightly out of there. So point is, you have to sell what is the need of the market. I have not made very many slides and all, but whatever little I will be, there is a pointer. That's right. So we have to sell what the market needs to view. This first slide itself is suggestive of what I am talking. Is it the next generation endotracheal tube? Yes, maybe. Why not? Maybe. Of course, there will be factors against it. अगर CA BG में डाल सकते हैं LMA. But yes, I am wise enough not to use it in a patient who has got a gangrenous gallbladder. So yes, there will be difficulties, but why not? I have started my first laryngeal mass when it was costing 18,800 rupees. And my first patient, when I took it out, beat it with the incisor. You can imagine, वो टाइम पे मेरे को 12 टायर मिलता था वो भाव में. I actually went to a tire fellow. Can you mend it? He said, "Sir, kuch nahi kar sakte." So I have evolved from that level. Today I work in a center where they do infertility work. So they have 15 to 20 infertility surgeries, and they tell me, "Sir, आज खाली 4 beds खाली है." So now I have only this thing left with me. I am not going to use anything else. मुझे intubate करके उसको शाम तक वहाँ नहीं रखने का. उसके पास खाली 4 ही bed है. He is very precise about it. So tomorrow is meant for that. Tasneem said daycare surgery. I am not daycare. I am our care. When the third patient comes inside, when my third patient comes back to the ward, the first one is already wearing sari and eating vanilla ice cream. Because the element that the xylocalin is very bitter. So I tell my surgeons that you must give vanilla ice cream to the lady, her mother, and her mother-in-law. All three of them come. Infertility wala astat sagla yeta. This is my most favorite slide. Chill. And this guy, Brimacom, you have seen him. He can stay for hours together wearing an LMA underwater. He conducted a study where he ran 5 miles with an LMA to prove that there was no resistance. I was comfortable. Means it is that to that level it is. And of course, I am not going to show the types of LMA. Now there are so many available in market, and prolonged anesthesia will give all those things. If you are going to put it for 10 hours and all those things, it is going to give. But I have put for 4 and 5 hours also. And of course, many of you have seen my insertion of LMA in prone position also, which I do it just like putting a tongue depressor or GP puts. Point is, it is because I was working in Priyanka Chopra Center. Only one ward boy. And the next slide, people ask me, I said, there's only one ward boy. And look at the next slide, where there are 13 people trying to turn one patient prone. इतना cosmetic center में इतना staff नहीं मिलता है, especially when the patients are हेमंत साहब का तो level पे नहीं जाऊँगा, लेकिन फिर भी it's not that. I have literally given liposuction of you name it, everyone. These are all theories, of course, time permitted and all those things. I'm not interested in those things, and nor am I interested in trying to show a video. But believe me, just one small video, if it plays, I'll try and show. If it plays, I guess it plays. It's an animation video, but the point is, it will go and block the esophagus. I'm just trying to say, it is going to go and block the esophagus. Can it run a little faster? Is it possible? Is there something there? Nasta guy, hey, programmer. Okay, I thought, yeah. No, but then I'll be finishing my 7 minutes much faster than I will actually edited everything. See, this just goes inside that esophagus and it simply blocks it. The point is, there is not much room for aspiration. This again, at the same time, I'm not going to show this video also. Pressures. Intra-abdominal pressure can be more, or LMA cuff pressure may be more. You have to balance between the two. Position of the patient. Either it is extreme head low, where I've seen my gynecologist touching down there, head low. It is almost touching the headboard, otherwise it is not going to go further down. Bariatric surgery, I love it. They are practically vertically standing. I don't know if you have noticed. At times I ask them, prone zopla ki supine zopla? The way they put that thing, you cannot make out his prone or supine, honestly. Anyway, jokes apart. Aspiration. This is one thing I love. Mendelssohn syndrome. The Jesus Christ डोक्यामध्ये last the खिडा ठोकला होता ना. It is hammered in every new anesthetist's mind. That study was conducted from 1946 to 1953. Believe me, I was born in 1953. त्यानंतर किती medicines आली आणि काय काय नाही आला. And still that hammer is going on. Mendelssohn. I have seen Mendelssohn, but in spinal anesthesia. 4 cases, not one, in 4 cases, but not in GA. So let us not get carried away, especially when you are going to put some line to drain out things. It also depends on surgery. Is it a gynec surgery? Is it a perforated appendix? I am wise enough not to touch it. Are you doing a diaphragmatic hernia? No, I am not going to touch that. Sorry. So those things, of course, I understand my limitations, and my surgeon, somebody just now mentioned, surgeon should be good. If you are presenting certain paper, it is because your surgeon is doing that. Believe me, you are nobody, it is because your surgeon. I have worked with surgeons who finish lap call in 7 and 10 minutes and diaphragmatic hernia in 20 minutes. So it all depends upon your surgeon. Don't even say that I am doing this and I am doing that.
We have no role to play in that.
True, very true, very true. And the patient, of course, patient factors are there, short, big. All my patients are liposuction. I did one liposuction on a corporator. And after half, they are typical like this much chest and this much stomach. आणि मी सगळं संपूर्ण बघून शिफ्ट करून घरी गेला. एक तासानंतर the technician was there, no? One boy was here with me since morning. He was there. He came and I called me, sir, मी आता आलो, काय करू? I said, जरा जाऊन तो corporator बघ. So what he sees, the surgeon is giving mouth to mouth on that giant fellow. Surgeon is giving mouth to mouth. Somebody is doing heart massage. आणि 3 शिवसैनिक आतमध्ये बघतात त्याला हा काय करतो म्हणून. He ran down, brought an element, inserted, and that fellow, काय झाला. I am blessing him still. नहीं तो वो तो मरा होता, मैं ऊपर लटक गया. So your patient selection really matters. But if possible, you can do all those things. If it's a clean abdomen, gynec surgery, gallbladders, appendix, biopsies, क्या निकलता, fertility related, we do all kinds of surgeries. Surgeons are experienced, trained, and they are very understanding. If they are not, I think better not to do those things. Positions, I just mentioned what different kind of positions are given to them. Morbidly obese, elderly, and children, I'm not going to touch them. No question about it. Always a drainage tube is kept, and nil by mouth and pre-med is covered properly. Trauma, aspiration, displacement, all those are known. But then, as I said, aspiration, don't take it that badly. Nowadays, we give pantoprazole, Rantac, and any pH more than 4 is not going to kill. The effect is same as injecting normal saline. That is mentioned in literature, and that is not my say. Displacement, अंदर गया तो वापस बाहर निकाला. अंदर तो एक साइड में जाना वाला नहीं है. बाहर आया तो वापस घुसाने का. What is so difficult about it? If I can do that in prone, why can't you do that in supine? What is the problem? Time, dosages. I think I'll give up here. Is it advisable? What are the legal aspects and what are the national guidelines? But for scopital, what are the national guidelines? I would not touch for scopital because the guideline family planning has decided it has to be endotracheal tube. I would not be wiser. I'll put an endotracheal tube. I think that's all. I am not going to show any of those videos. Thank you very much.
You mentioned about drainage tube. Do you mean rice tubes?
Sir, rice tube, no, it doesn't easily go. Okay. Try that. It doesn't easily go. But the orange color suction catheter, it goes perfectly into the stomach and drains out. Occasionally that also fails. But only then I take a rice tube. Otherwise I don't. Rice tube actually somehow it gets folded. That curve that is given in packing, rice tube is manufactured in such a way that the first curve is such that after that first curve it enters the trachea only. And endotracheal tube is manufactured in such a way. That's why I always, I don't know if you've seen my photo, I always hold my endotracheal tube like this. And then when I intubate it is nice and round. It's a must work. I'm sorry. Thank you very much. It was a pleasure coming to Pune. I'm a little too late running back to Mumbai. Thanks a lot. My next speaker is welcome. Please come. Thank you. Amit, I've woken them up. So now you are in front.
Well, there is no comparison between your expertise and my expertise. Well, I'm Dr. Amit Bhargav, working with Jupiter Hospital as a senior consultant. So we'll be dealing with, of course, for conventional and DT tube for laparoscopic surgeries. So supraglottic airway device for laparoscopic surgeries, of course I am going to speak in the favor of endotracheal tube. So why the debate about the airway? It's because supraglottic airway, as he said, are gaining popularity over the last decade and they are replacing the conventional ET tube. Points in favor: ease of use, less technical, muscle relaxation can be avoided, less chances of spasm and sore throat, etc. But despite its advantages, concerns still exist over the safe use and its ability to prevent pulmonary aspiration. Positive pressure ventilation may be a risk factor for pulmonary aspiration with SGA because of the gastric inflation.
So we should be beware of what is happening in the society as led by Dr. Bhatt. The indications are expanding. People are just expanding its indication use of supraglottic airways from the surgeries. The second generation, they are replacing the ET tube, and the pharyngeal, laryngeal morbidity, throat dysphagia, dysphonia, they are less as compared to the endotracheal tube. So the anesthesia concerns, we are not going into details about CO2, pneumoperitoneum, its effects on systems and all, patient positioning, with head tilts in extremes, surgical complication, peripheromediastinum and all, and patient-specific conditions. So intra-abdominal pressure with CO2 inflation, we have decrease in cardiac output because of the decreased venous return and cooling of blood in caval compression. In the respiratory system, we have reduced FRC. Already FRC is reduced with the general anesthesia, which is further reduced by inflation in healthy individuals, and which comes to the normal values only after 15 minutes of abdominal deflation. So similarly with the PaCO2, the PaCO2 which goes up, is the correction is achieved only with the alveolar ventilation when we increase it. So that is the one thing. And the respiratory complications, as we all know, so endotracheal intubation is the only saving grace in all these clinical scenarios of pneumothorax, pneumomediastinum, gas embolism, aspiration of gastric contents. A secured airway which can prevent and help in these situations where PEEP and positive pressure ventilation is under control is mandatory, and that is why we should go for the endotracheal intubation. All the evolution of supraglottic airway devices has been based on this breathing channel added with the gastric channel that takes the LMA's supraglottic airways towards the ETT, and there are different tests to conduct to find the correct placement of SGAs. But what are the caveats in this laparoscopic surgery is that it is a limited cohort of selected patients with no non-obese, no comorbidity, low risk of aspiration, as he said. Duration of the surgery, short duration, and mostly gynecological short procedures, and careful choice of anesthetics and the setup. And the only thing that all this evolution of SGAs is to achieve that satisfactory seal. All the studies that we did, they always justify its use, saying that the seal, esophageal seal, is satisfactory as compared to the ETT, but it is not that perfect seal. And without the proper seal, the ventilation is always compromised, and hence the satisfactory seal of SGA is always inferior to the conventional ETT. Plus Trendelenburg positions, overpowering surgeons, sheet shasan kar dete hain wo, that cause cephalic displacement of diaphragm warrants perfect seal that can be provided by the much needed positive pressure ventilation through ETT, which is not guaranteed by the satisfactory seal of any generation of SGAs. So what can go wrong with the SGAs? It's wrong patient selection. It is not that only the expertise give anesthesia, it's the junior, novice, the new people, they give anesthesia also, so they should learn that there could be a wrong patient selection. There is a lack of uniform training of the anesthetist, so the junior anesthetists have problem of insertion and perhaps poor placement. But one thing which I would like to tell the juniors is, never consider supraglottic airway as plan A for an anticipated difficult airway. It is a rescue device. This is separate from this debate, but this point I want to give, so that when you leave this 2-day of conference, you go with this point in mind. So what else can go wrong with SGAs? And non-aspiration events like dislodge intraoperatively. This can lead to laryngospasm and awareness, which is medico-legally suable. Oral trauma. We need to change the ETT intraoperatively for the reason that is cumbersome. It could be easier than the endotracheal tube placing the supraglottic airway device, but maintenance of the case needs full vigilance of highly experienced anesthetist. So I went through this NAP4 project of United Kingdom. They are the projects which are studies conducted to improve the quality of practice. And this was done although in 2006-07. But this NAP was done for the complications of airway management. And the salient features were the safety is an important anesthetic issue with significant clinical and legal implications. Majority of SGA related complications were aspiration, and this included most of the worst outcomes. There were case that was published. While SGAs have become routine airway devices, because 70% of the general anesthesia in UK is done with SGAs, there's always a risk of pulmonary aspiration of gastric contents, air leak during the controlled ventilation with subsequent hypoventilation, and displacement of the device during the use. And minimizing this risk is likely to achieve by careful consideration, correct patient selection, limitation of use of appropriate surgery, correct expert insertion, fixation and use, and vigilance during use, including recommended monitoring. There were few cases that were reporting during the NAP4 where there was an anesthetized by the consultant anesthetist with LMA. During maintenance, the patient aspirated, causing airway obstruction. Patient was intubated. At the end of the surgery, patient extubated but deteriorated further and died the same day in ICU. There is a problems during the maintenance on the supraglottic airway device, where the poor patient selection and light anesthesia were identified as the most frequent problem. This was following the placement of the single-use laryngeal mask by a very junior anesthetist for minor surgery. There was a delay before intubation, following which persistent hypoxia and post-obstructive pulmonary edema necessitated the ICU admission.
Can we have some comment?
Sorry?
Time.
I'll just close this aspiration and it's already been said. So my main thing is the safety is a parmodharma. Enormous literature is available which has reviewed SGA use in laparoscopy, but is always in selected cases by selected expert in limited cohort of patient for short duration and vigilance. So no tube breaks for consultant. SGA do not protect the lungs from aspiration as good as curved endotracheal tube does. Just because you can doesn't mean you should. And anesthesia malpractice is all the lawsuits regarding SGA in relation with aspiration looks into the standard care to prevent aspiration, making the defendant vulnerable. One bad day can ruin the careers of any expert, leave alone the novice. Safety and efficacy are the critical factors that would define SGA use in laparoscopic surgeries. While efficacy has been demonstrated in several studies, protection against pulmonary aspiration is not guaranteed. These are the basic LMA practices percentage-wise. References. Thank you.
Any question from audience?
Any questions for audience? One humble request on behalf of ISA Boreoli. As the president of the branch, I request all of you to kindly register for the ISA State Biennial CME, which is the other short name given to MISACON for smaller branches. So that is on 4th, 5th and 6th of November. Please register. Dr. Shilpa has been hammering away all day about the... I told her, why do Bijapudi QR code पाठवून तर लोक पैसा टाकतात नंतर नाव पाठवायला हरकत नाही आपल्याला. So as a Guju, I can take out money first and then decide everything later. Thank you very much. Please be with us. And over there, we are not going to invite any comedians. Me, Hemant Shinde. आणि आमच्यावर एक चेरी ठेवली तर कामदार सर sufficient आहे. Thank you very much. I'll be running away back to Bombay after probably a cup of tea if Jana sir is giving me. Thank you.
Thank you all. Thank you.
Thank you all. Sir. I now request our chairpersons to kindly felicitate Dr. Yogen Bhatt sir and Dr. Amit Bhargava sir. I now request our chairpersons to kindly felicitate Dr. Tasneem Dansura and Dr. Jui. I now request our chairpersons to kindly felicitate Dr. Ashish Patak sir and Dr. Pallavi Budhiani sir. Ma'am, sorry. Thank you, ma'am. Thank you, sir. I now request Dr. Saroj Bande and Dr. B.D. Bande, sir, to kindly come on stage and felicitate our chairperson. I now request our chairpersons to kindly felicitate Dr. Poonam Godgi, ma'am. Thank you, ma'am.
We now come to our last session for the day, which involves a spectrum of important topics that need to be touched upon. I request Dr. Prajakta Taide to come up on stage and take over the session.
Thank you, Dr. Ritvi. After the dynamic pros and cons session, we have now come towards the last lessons from our life lessons for PROACT 22. The topics for this session, though varied, are equally important for our day-to-day anesthesia practice. To chair the session, we have Dr. Sandeep Gore, sir, Senior Consultant at Joshi and Ratna Hospital, Pune. And along with him, we have Dr. Girish Saundartika, sir, Professor and Head of Department of Anesthesia at Srimati Kashibai Navle Hospital. I welcome you both, sir. I now request our esteemed chairperson to introduce our first speaker. The topic for him is the low flow anesthesia. How low can we fly? Dr. Rajendra Patil, sir.
Good evening. Probably the last session of the 2 days exhaustive PROACT conference. As everybody says, I also say so. He doesn't require any introduction. And we have seen him earlier for last 2 days and earlier also. He can finish the session like a jam in 1 minute, or he can go long and long and long. So I leave it to him. Over to Dr. Rajendra Patil, sir.
I really appreciate your patience.
Still many of the audience left.
Sunday afternoon.
Yeah.
Can I have I feel very close when I can use this mic here. So, no, really.
We are expecting more. Out of respect, we are expecting more.
Yeah. So, respect means there are quite a few office bearers, they cannot live anyway.
Yeah.
Some of my students here, they cannot live. One is my wife here, so she cannot live. So, anyway, jokes apart, you are the hallmark of this SAP, Society of Anesthesia. Okay? What do you mean by hallmark? Because, whenever you go for a conference, there are 3 types of people. Some are stalwarts. Most of the time you will find them in the stalls. Yeah. Some are outstanding. Yeah. Because they will be outstanding going from this place to that place.
And पहिले कॉन्फरन्स कुठली आहे जॉय सर कोण बोललं शिलाँगची कॉन्फरन्स आहे सो they will have a 3-day trek there and whatever but you are the hallmark of the I am going to just take 5 minutes just to give the clear message and then we'll wind up now. Okay, how much low can you fly? How much flow you're using now? Just tell me honestly. 4 liters, 6 liters, 2 liters. How many of you are using 2 liters? Almost all. 2 liters. Right. Yeah. Next question is 2 is okay. Anybody using 1 liter? 1 liter. 1, 2, 3, 4, 5. Okay. Now, if somebody asks you, you got a case here. So some of you are using. So just imagine a 42-year-old female patient, BMI of 36, going for a cholecystectomy. Generally, it takes 2 hours, right? If somebody asks you, how much sevoflurane have you used, or how much should I bill to the patient? What is your answer? 2-hour surgery, you're using sevoflurane or maybe desflurane. What is your answer? Anybody? 10 ml for 2-hour surgery. Okay. Any other answer than this?
1 liter.
Huh?
With 1 liter.
With 1 liter. That is very important, right? There is a formula here. Okay. Yeah, formula वापरा ना. Basically, it depends on the how much dial concentration you have, you keep, and how much flow you keep, right? So if you put all this figure for sevoflurane, it comes to 26 ml, and that will be the cost of 2-hour anesthesia with sevoflurane with flow of 2 liters. Okay, but if you use 1 liter, it comes down to 400 rupees. Okay, same thing with desflurane. 2-hour anesthesia will be 1600 rupees, and 1 hour. I mean, if the French gas flow is 1 liter, it will be 800. So you are almost saving 50%, right? And this I have been telling to all of you for a long time. I think we're still using 2 liters. Some people are using. Even I had asked the question in Amravati and Nasik, and they are still using in 4 liters and maybe more also. So basically, the message is that we are almost using. If you just come down from 2 liter to 1 liter, you're almost saving 50%, right? And if I want to, if you're doing this 2-hour surgery just by reducing from 2 liter to 1 liter, you're saving almost 50%. That is 400 rupees. Okay. And if you are doing 2 cases per day and there are 300 working days, you are almost saving 2.4 lakhs in a year. Just imagine 2-hour surgery, 2 cases per day, and you are working 300 days in a year. You are saving almost 2.4 lakhs in a year. And if you are using desflurane, almost 4.8 lakhs. So you can buy an agent monitor for this, right? And I've been telling this, right? But what we should put this now on Amazon, that there is a 50% discount on sevoflurane and desflurane, and there is a small line there, condition apply. Just reduce your flow from 2 liter to 1 liter, and that should actually. So this was basically just the formula. It is a static condition, but in anesthesia it's a dynamic situation actually. You keep on changing the flow, you keep on changing the dial concentration, right? I wanted to show you something on the Gasman software actually, but we do not have much time, right? But I have taken this snapshot, and I think it says same thing, that when you use 2 liter of sevoflurane, okay, this is the fresh gas flow, and this is the dial concentration, and this is basically 1 liter. So agent consumed by the patient is again 270 rupees, 280 rupees. It is the same because the patient is same, but if you just reduce the flow from 2 liter to 1 liter, you are almost saving 400 rupees. Okay. So it's the same thing actually if you are using this Dian's formula or using this Gasman software. So again it comes down to the same thing, right? Just by reducing from 2 liter to 1 liter, you are almost saving a lot of money at the end of the day. Okay, right? 52 seconds. Okay. Now, would any one of us continue to pour petrol when the tank is full? Okay, we are so sensitive. एक पण रुपये वाढला ना, okay, so we are this become national news, breaking news, right, and उद्यापासून पेट्रोल वाढणार आहे. So UK पण there is a long, this is from the सेनापती बापट road actually, I had taken this picture. And there is a long, अरे पेट्रोल बराबर भरून घ्या, उद्यापासून महाग होणार आहे. We are saying 80 rupees पासून 81, right? But what is the cost of the inhalation agent? Sevoflurane 28,000 per liter, and desflurane again 28,000. So it is almost 150 to 400 times costlier than petrol, right? So we just look at how we can reduce. If somebody is using 4 liter, try to reduce from 4 to 2 liters. If somebody is using 2 liter, we can still go down to 1 liter, and even lowish as far as you are comfortable. We all know about these advantages, that it is less wastage, less expensive. You can have a steady and safe anesthesia. You got a warm patient, moist absorbent, and at the end, planet friendly, right? We all know about the global warming. We all know about I just wanted to put here the global warming potential of desflurane is 3,700 and that of isoflurane is 1,400, right? But the lifetime, that is called as a tropospheric lifetime. The nitrous oxide remains in the atmosphere for almost 114 years, more than 100 years. So whatever was used in last century, we are still having it in the atmosphere, right? So basically, depletion of the ozone layer and global warming cause. So we should be using less and less flow now, so that there will be less wastage. At the end of the day, all these chlorofluorocarbons will be banned by 2030. That was the Montreal Protocol, and we got another 7, 8, 9 years, and we should be getting rid of the sevoflurane, desflurane. Okay. So what we need is basically, a good machine with ETCO2 monitoring, end-tidal anesthesia, your MAC monitor and FiO2. Okay. There are quite a lot of concern whether I will be delivering hypoxic mixture, or uncertainty about the agent concentration, and whether I should be using low flow with sevoflurane. Okay, but it is not a rocket science. It's actually just the fear of unknown, and you feel uncomfortable. But as long as you are using low flow and you got a gas monitor, we should be using, right? The last 2 slides now, we know the oxygen consumption. It's this Brody's formula is 10 into body weight, the 3/4 power of the body weight, right? It's not very convenient to calculate that, but the thumb rule is the oxygen requirement or the consumption is 5 ml per kg per minute, right? So if you can have, so the 70 kg patient will require oxygen around 350 ml per minute, right? And if you're using air, or if you're using nitrous oxide, if you can just give 500 ml of air and 500 ml of oxygen and 500 ml of nitrous or air, that should be suffices, right? And just this last slide, right? If you straight away go to low flow, okay, you may have a value of no anesthesia. Okay, what happens here? You induce with propofol, and if you suddenly go low, you won't be able to achieve adequate MAC, right? So then there is a value of anesthesia. This generally happens with laparoscopy patient, the gynec patient, they are already ready, and then you can have tachycardia and hypertension. So you should be giving high flow, high dial concentration, achieve 1.5 MAC, and then start reducing the flow. Okay. So it takes about 10 minutes to get the 1 MAC, and then you can reduce it. So basically, more of the story, start using low flow. You can buy agent monitor with that much cost saving within 1 year, and save the cost of inhalation anesthesia and avoid pollution and save the environment and our planet. Thank you.
Madam will be talking on, I think, endoscopic monitored anesthesia care in ERCP room. MAC is a very tricky subject. Most of us take it very lightly, especially when a MAC is given outside the OT. You have to be very, very careful, because patients, they come to ARCP in a different critical stages, different ASA grades, and we should not take it lightly even in the OT, main OT. and not to talk of the peripheral remote control OTs where we work. So I hand over to Dr. Jana to deliver her topic.
Too short as compared to him and him to stand there and talk to you all. So good evening to all of you. And let's not consider ourselves as night watchmen. We are like desserts at the end of the meal, okay? So we are here the last. And I don't know about the rest of you, but the first problem that I face with ERCP or endoscopy is की माझ्या गॅस्ट्रोएंटरोलॉजिस्टला शाळेत असताना घड्याळ अजिबात शिकवलेलं नाही. त्याला घड्याळात 3 कसे वाजतात आणि 6 कसे वाजतात त्यातला फरक कळत नाही आणि संगती संगत असणं असं त्याच्या पेशन्स नाही कळत नाही. त्यामुळे ते दोघे केव्हाही उगवतात. So leaving apart that, I was given a topic by which I was a little intrigued when I read it. But as I thought about it, I thought probably it's something that we all face very commonly when we are doing our practice. So for the sake of convenience, I've just divided. Hey, how does it scroll here? Just scroll and get the side. I can't see it. Yeah. No, just go further. Okay, it starts here. Okay, so for the sake of convenience, I've just divided it into 3 things. One is lower GI scopy, upper GI scopies, and ERCPs. Now there are various indications for which a lower GI scopy would be done. One is screening, a PR bleeding, a family history of polyp or Crohn's, and in those cases, alternative constipation diarrhea, obviously to rule out the malignancy. Now what are the indications for upper GI scopy? It's not happening. I need your help. So the upper GI scopies are done for various reasons, like if you have a esophageal varices which are bleeding, then you would have they are done for GERD, they are done for strictures, esophageal varices, tumors, hiatus hernia, acalzia cardia, and for foreign body removal. ERCPs are done either for pancreatic calculi, either they are done for bile duct calculi, or they are done with malignancies causing obstruction to put up a stent. Now, amongst all this, let's finish off with the low GI scopies, where relatively the anatomy is simpler, the procedures are simpler, and probably we could get away with MAC or giving sedation to these patients. Again, barring the geriatric age group above 70 years of age, probably you won't do that even under MAC. Now we come to upper GI scopies. So when we talk of upper GI scopies, the indications are such that if you have a patient with a esophageal varices and is bleeding, then the chance of him aspirating the blood is high. So probably I would prefer to have a secure airway rather than giving a MAC to this patient. Similar applies to a patient who has got a corrosive injury to the esophagus, has come for esophageal dilatation, is in the case of CA esophagus and has come for stenting. Now in these patients, many of them are unable to swallow saliva also, so visualizing the airway under critical conditions is difficult, risk of aspiration is high whenever Mendelssohn lived, but still in those patients I would definitely prefer to have a secure airway. The another thing that happens with esophageal dilatation is esophageal perforation, either causing mediastinal emphysema or causing surgical subcutaneous emphysema. In both this situation, mediastinal obviously is more challenging for us to deal with, and I would definitely prefer to have a secure airway in these patients. Now these are the few hiatus hernia, acalzia cardia. If they are to be done just as a diagnostic, probably MAC would be good enough. Now removal of foreign body from esophagus comes generally either in extreme geriatric age group or pediatric age group, and both probably would warrant that you intubate your patient rather than giving just MAC to these patients. Now comes ERCPs. Now ERCPs also, if they are performed for ERCP is done for calculous cholecystitis or hepatic stone, hepatic duct stone, then they are relatively easy technically to perform, take a shorter time, and could be done under MAC providing you choose your patients carefully. Now when I say I choose my patients carefully, that would mean that again, morbidly obese patients probably, even if it is a small procedure and he says ki mala 10 minutes lagnar hai, we don't trust him generally, it doesn't happen that way. And for a patient to be lateral under sedation and obstructed with obstructed airway, pharynx collapsing, to even turn the patient supine to resuscitate becomes a task in itself. So probably in those cases, I would still have a secure airway when I can do it more systematically than in a randomized haphazard manner when my patient has obstructed. Now, carcinomas are always difficult to deal with and stent, and in those cases, the procedure takes a longer time. I always believe that in ERCPs, the procedure time matters. One is that the gas insufflation of the abdomen for that long time makes even a lean, thin patient uncomfortable at the end of 2 hours to breathe. And nowadays, they've started using CO2 as an insufflating agent, and you would have a sudden CO2 surge in these patients, giving all the hyperdynamic responses that you would get with hypercarbia. And the patient is obviously not going to generate that much minute ventilation to wash out that much amount of EtCO2 if they're going to do it for 2 hours. So in those cases, we have decided that more than 45 minutes, if a procedure is going to last, then we prefer to intubate our patients and be safe.
When do they tell you that it is going
No, they never do, ma'am. It's for us to anticipate and to decide. For them, it's never like that. They never tell us. Now, my slides are not scrolling again, dear. Scroll, Kar, please. Now, there are a few things that I want each of us to understand that probably many a times we face these kind of situations at the end of the day when we are tired. He's not there in time. The patient is waiting. Yeah. So, what do? First thing is that you please have some protocols for yourself. If you're working in an institute, have a department to back you. As a department, form protocols that these will be followed. Whether person A goes, B goes, C, D to Z, whoever goes there is going to follow a certain institutional protocol to be done. If you are an individual practicing anesthetist or practicing as a group, have protocols for yourself. And the protocol should also include as to which patient do I accept on an OPD basis who comes for ERCP or a scopy, whom I want admitted. Now, this dilemma comes majority of the times when patients come with malignancy for stenting, they are elderly, they have a lot of comorbidities. And second thing is because of malignancies, they have deranged hepatic functions. Maybe because of metastasis or because of the sheer obstruction that they have. In those cases, they carry the risk of anesthesia than any person with deranged liver functions would carry. And here, you are giving anesthesia in a remote location without any safety guidelines. So don't get into that trap. Ask them to admit the patient, do a proper PSC. You want a high-risk consent, take a high-risk consent. You want a post-op ICU, please book a post-op ICU, explain to the patient, and then do the case where you will be safe. We are not getting any gold medal from any of them for doing it in any other way. Monitoring, follow all the standard ISA protocols for monitoring. EtCO2, I always say that you must, especially as I said now, they are using EtCO2 as an insufflating agent to a large degree. So please do your EtCO2 monitoring along with the routine monitorings that you would do. So another thing that we face is the out of OT anesthesia scene. Quite a few people have already talked about it, and the two major things that you would face is, one is lack of gadgetry that you would have there, and the second is lack of manpower that you would have there. A trained assistant probably is easily available in the OT than in these scenarios when you are in the periphery. So the message from me is more. It's never just a standby, even if you are asked to believe it. Then follow all the protocols, have proper anesthesia equipments, monitors, drugs, assistance. Procedure longer than half an hour, 45 minutes, please do intubate. And please, if you are doing a high volume work as we are doing in our center, please insist on having a recovery room which is adjacent to these places where you are performing endoscopy, that you want to keep any patient there for half an hour, 1 hour, till you are satisfied that the patient has recovered adequately either from your sedation or from anesthesia that you have given. That patient can be monitored safely. Because again, as Hemant was talking, whose fault is it anyway if something happens to these patients? And another thing is, if they are not coming for a corrective procedure, like a stenting or whatever, it is looked at by the patient as a diagnostic procedure. And so nothing should go wrong while he is being diagnosed for something and not treated for it. That is another onus on us when we anesthetize patients, either for ERCP or for diagnostic so-called scopies. Thank you so much at the end of the day for your kind attention. Thanks a lot. And thank you, Pradnya, and everyone, all the organizing team, for giving me a chance to be here today. It has been wonderful 2 days. Thank you.
We'll keep the question answer sessions at the end of the last speaker. I don't think there will be any, but still, if they are there, they can be discussed after the last speaker. So, the third speaker is Dr. Sarang Puranik. He'll be talking on non-technical skills in anesthesia.
I really thank your tenacity for waiting for so long. ते मुंबईचे गेलेले सगळे थँक्यू थँक गॉड फॉर दॅट कारण की आय डोंट नो हाऊ टू फॉलो युअर डॉक्टर शिंदे the only thing remaining for me to do Shirsasan and do my presentation.
No, you can
No disrespect. I've learned.
You can anesthetize Alia Bhatt.
I was thinking who I had done something with. But I've learned a lot of things. Absolutely. So just to say, I'm a hardcore Punekar and BGI, even though I've not been here for last almost 25 years. To be honest, this is one of the most important topics. Of course, I would believe that. You have learned how to do anesthetics for last 2 days now, which needle to use for your spinal 29, 30, whatever it is, and really low flow. Everything is saturated. I don't think you can learn how to give anesthetic. But I think this is the most important aspect of anesthesia, which is ignored, and it's been highlighted in the last 2 decades, and more so in the last decade or so. Why so? So hopefully I will try to convince you, and those who are really interested, who have been here for last 10-20 minutes, will take home the messages which I give you and spread it to your trainees, and more importantly for the trainees of today's generation. So, do I press that green button here? I think the reason why Pradnya asked me to come last, I know now, because she wanted me to be a spy, so that whatever the speakers talk about UK anesthesia, I can go and tell them was it correct or wrong. But don't worry, whatever remains here, whatever is spoken in this room, it's not getting forwarded button here. So basically, if you can forward it for me, okay? Tell me what to press. I can press it. So basically, okay, absolutely. Thank you, Aman. So crisis resource management, or in fact, before that, if you can forward the slide, will be a good idea. It's not even going forward. That must be PuneCon. Con of Pune meetings, you know, something is going wrong here. Conspiracy. So nothing is working. It's not my fault. I'm sorry. The hand control or even the computer control. So just
technical skills to
exactly. So I will carry on. Thank you very much. I knew. The senior most anesthetists, I'm sure, will come to help me ultimately. So thank you very much. So I will carry on. Do not worry. मी कालच सगळ्या वाट केल्या slides. So I declare no conflicts. I have no interest on any of these talks or slides I'm giving. But I wish there are no conflicts in the world as well, such as Russia, Ukraine, etc. So okay. So that is what I mean by no conflicts. So what I'm talking about, I'm going to talk to you about what are the skills, like anesthesia non-technical skills, something to do with CRM or crisis resource management, and some other techniques as well. Why me, you may ask? Well, I have led and done a lot of activities such as roles in leading simulation in our hospital, what we call as trust. I've been a lead of the trust audit, risk management. I'm airway lead at the moment. I also mentor the new consultants in our hospital. And I'm going to tell you a little bit. Do not worry, you don't have to press. I will finish in 15 minutes. So the high risk industries such as oil and gas, nuclear, and I must mention this one where my colleague just returned last week, HEMS, we call it as helicopter management, medical management service. And they use, to the point, crisis resource management on daily basis. And that is one of the important aspects, and how I will go through quickly. Again, to mention NAP4 and 5th national audit. Majority of the airway complications were blamed due to the human factors. Dr. Shinde has mentioned about that, as well as the 5th national audit project, which was published in 2014. They talked about 73% incidences were because of lack of communication. So human factors, we probably should know that, is the science of improving human performance and well-being by examining all the effectors of human performance. And when we talk about human factors, this is the name. And if you are interested in these things, the website given there, I'm sure will be really interesting for you to look at. In 2005, his late wife died needlessly during a routine ENT operation. And anesthetists involved were consultants of many years of practice, and she died in spite of all that. And there is huge information on the website. What he did was he didn't sue anyone. Instead, he started this organization, Clinical Human Factors, and he is now giving speeches all over the world. This has been going for the last decade. What he says, we are all wrong, no matter how good we are. We need people around to tell us, and be open to suggestions. Listen to your team, step up and lead. It does not matter what amount of experience you have at the back. It still happens, and we have gone through all this already. Why do errors happen? Errors happen, but it could be because of no fault of yours, it could be systemic errors, or it could be cognitive errors. So that can be divided. But we have major and huge role to play, and that is what I'm talking about here. These factors are divided into cognitive, social, and personal resource skills. This is the busiest slide, but they are divided. What they did was the industrial psychologist and the anaesthetists in Scotland did a research project for 4 years, and they came up with something called as anesthesia non-technical skills. And this is one of the things nowadays we practice whenever simulation is happening, as well as their performance is checked practically. So these are the categories, basically 4 categories as you can see. But if you look at it, these things happen on a daily basis. I'll come to that a little bit more, but planning, preparing, prioritizing, providing and maintaining standards, these things should be happening every day, not just for emergency cases as well. Teamwork, coordinating activities with the team, exchanging information, using authority and assertiveness, assessing capabilities, supporting others, and really important one, situational awareness. That is, what is really going on? What is happening? If the people were talking about alarms going on, sometimes having the oxygen mask on your face, but oxygen is not connected to the wall. And that is easily done because there are 2 or 3 patients next to each other. Very easily done. And decision making as well. So you may say, well, that's all right. You can say, well, this works in your big institutions. I just do Dava Bartley still, or whatever else you do as a solo practitioner. And I was happy to see that group practice is working. But in each and every theater, irrespective of the place you are, you still have a really important role. You are a leader as an anesthetist, wherever you practice. It's really important to take that initiative and lead the team. It's important that you work in the team could be any time. It could contain 2 people to 10 people. It does not matter. You can still have huge impact on what you do and increase the team effectiveness. Communication is the key. And as I said, open and effective communication is really, really important, especially in emergency situations. Because you may order something, can you get something for me? And if you haven't said that, tell me when you have done something after that. There is no value to that. So it is important that you really communicate properly, and team dynamics as well as listening are really, really important skills. 3 C's of communication, cite names. So don't say, oh, just get it, something. Just say your name, or his or her name, and say, Sandeep, can you get something for me and tell me when you're done? It gives him importance. That is really important. You can't just say, Yunya to you. And hence, when we do the who, we ask each other's name. That happens on each and every day. And I'm not just saying because it is written in the books or some journals or something like that. Clear instructions are important, and closing the loop, as I said. So what are the 3 C's of high-performing teams? Capability, capacity, and culture. And if you have any one of them missing, you can lose the whole plot. And that is one of the important aspects you need to remember. So it's not just what we are talking about, what is happening, but it is also, this is the syllabus of Royal College of Anaesthetists as of today, which is a new curriculum, and that has given importance to team working, as you can see. And that is important to inculcate in our trainees right from beginning, and your job is to do that for your next generation as well. And I hope that the consultants here also take some of the hints from that as well. This is another important aspect, civility. How many people of us here know the boss from hell? And we all have faced those situations. And incivility is one of the really horrible things that can happen. It's one of those things. The civil work environment is one where employees respect, value one another through cooperation, fair resolution of disputes, teamwork, and non-discriminatory behavior. And we all know how rude surgeons behave at times. And there are a lot of studies showing that even in simulated events, if the surgeon is rude, the performance of whole team as well as anesthetists deteriorates. It's important that we realize that and we create atmosphere of respect within the theatres. The victims of incivility are all of us, not just us, as we talked about, second victims for whatever reasons, the recipient, bystanders, patients, relatives, and the whole team. It creates a really bad environment in the team. Another initiative we started, me and my colleague in our hospital, which has been started in UK about 6-7 years ago, was learning from excellence. So when we are working in a team, and even if you're porter or some ODP, the nursing assistant, doesn't matter. If they help you and save the situation, give them credit. We need to give them some recommendation perhaps, or email or certificate or something like that. It creates a huge increased morale in the whole team. And that is really powerful tool, and we do that all the time in our hospital. It does not matter, it needs to be, it doesn't have to be like big thing, something that somebody saves somebody's life. Somebody might have just brought equipment which you really needed at that time. And it can create huge morale boosting thing. So what are the other important roles? We talked about low floor. I think it is imperative that we take the initiative ourselves and start. I have learned, I'm sure, Dr. Bhatia, you must have taught us, not me personally, but some of our colleagues, that make sure you use 6 liters or whatever. Madam, you must be knowing that. That is what we have been taught. But the times have changed. We know what are the impact of Dr. Rajendra has already alluded to the nitrous oxide and desflurane. In fact, most of 80% I think hospitals have stopped using desflurane. And Royal College has said that we should not be using. A lot of hospitals, including ours, have now environmental anesthetists specialists. They are leading that cause and making sure that whenever possible regional anesthesia is used, and we don't use nitrous, especially when regional is given. And we can all do that. You can become well-being champion. I don't need to tell you all that. COVID has just passed. We have learned huge amount. We really need somebody, if you're working in an institution especially, as well as good practice, it's important to have somebody as a well-being champion. You can help each other in a group. It's really, really important. Risk and safety lead and excellence champion. So being an anesthetist is the best job in the world. Of course, I would say that. I'm an anesthetist. Human factors and non-technical skills must be incorporated and used together along with clinical techniques and medical knowledge, which hopefully you would have now anyway. And anesthetists have a much bigger role to play in a theatre. And get educated, spread civility in your working environment, and be the champions of environmental protection. Thank you very much. The first clip, I hope, on the first bell. Thank you very much.
Any questions are welcome. Is there any? Or any suggestions, any comment? If not, we can end the session of this 2 days executive PROACT conference.
I request the chairpersons to kindly felicitate our speakers, Dr. Rajendra Patil, Dr. Archana Jana, and Dr. Sarang Puranik. request Dr. Samir Kulkarni sir to come up on stage to felicitate our chairpersons, Dr. Girish Saundattikar and Dr. Sandeep Gore sir. I request our chairpersons to felicitate Dr. Prajakta Taidu. Now, to conclude the scientific program, I invite on stage Dr. Sunita Khedkar, who will deliver the vote of thanks.
Now the jam got released and the result is out now. So, Dr. Sari, I will request you to give prizes to the jam session. So the second prize goes to Dr. Mona. She is a resident at Very good. And the first prize goes to Dr. Poonam. Pallavi, you can tell. Thank you, sir. Sari, sir. Dr. Rashmi Valimbe, please collect your certificate. Dr. Rohit Wagmare. Dr. Nupur Chaudhary. Thank you and congratulations to the winners. We come to the end of this academic feast of 2 days conference and 1 day pre-conference workshop at Ruby Hall Clinic and the Dinanath Mangeshkar Hospital. On behalf of organizing team of PROACT, I would like to thank the faculty for enlightening us. All the lessons learned in their years of practice, our chairpersons for their inputs and the coordinators. I would like to thank our sponsors, the audiovisual team, the stalls, Mr. Moile, the Crowley Plaza team for their help throughout the conference. I would like to thank the delegates for being patient during all the sessions and tolerating a few hitches which may have occurred. And last but not the least, I thank our executive committee senior members for guiding us throughout the organization of this conference. Thank you all.
Three cheers.
And Mr. Dhanuka for registration.
Alright, let's give 3 cheers and a standing for the
Before we end, let's thank our master of the stage, Ruthvi and Rohit, for conducting the whole program very nicely. Rohit, Ruthvi, come. Pratya, very nicely. Sujit, come.
Come on, madam, very, very well conducted. Please close.
On behalf of all the audience and executive committee members who were here, who were not here, I must congratulate the whole team because this was the first time I was away from the managing the scientific sessions. And I have a lot of feedbacks that one of the best scientific sessions so far, besides the technical problem, but otherwise I think everybody enjoyed. It was a smaller group and there are a lot of interactions took place and that kept everybody alive to listen each moment of all the good speakers and all the choices. I must, not because my wife was in that, but even otherwise तुमच्यासारखे सगळे इंटेलिजंट नाही कोण तुला विसरलेलं नाहीये तुला विसरलेलं नाही but Pradnya, lot of credit to you. Very well done. Very well done.
3 cheers.